certainly people around, yeah, depending on who the speaker is. We should at least, there's no reason not to allow you like the people. I mean,
It was still on our event page.
Yeah.
So like listed in the lineup, I'm sure.
And who decided that we shouldn't send it out for a million lists because people want to put it into use?
So Ryan and I talked to Jessica about it, and she said it's really speed focused.
Okay.
So
I really thought that.
yeah, we went with that.
I mean, it is, but it's only because of the name.
Yeah, I mean, we can turn it into the other things, no problem.
Where's the name?
Celia. Not if I get it more than 30 days.
Let me talk to Jessica.
So I think the next one's an 8 still.
Yeah, no, we'll probably have one.
Okay. So in any case, probably that's still the market.
Right. Oh, no.
Yeah, okay. So that one will be no problem.
No.
I just learned to speak Italian today. Okay, I didn't. Couple.
And Robert, so we're all set. Staying around for
No, my mother. If I need to bring that around.
yeah. We have a group of people that get together every year for this.
Oh.
Well, I do it on the roof.
Oh, interesting.
Where you can you can't stop it.
How often?
Depends on the size of the turkey, but we have a 20 full-time turkey. So it's probably 6 hours or so.
Okay, yeah.
Keep it close to it. So
What's the lunch?
if it's really raining hard, I'll put the one. Goes out very, because it's so hot that it sears the outside of the turkey, and so it holds the chicken wherever you want. Then I have to make the 7 hours.
Come in. Help yourself.
Mm-hmm.
That's yours, right?
Yes.
I was gonna say, looks like it's either Metro
Metro.
or Michigan, I can't tell.
M.
The color.
One of those M. The course is an hour, roughly.
This has to end before one.
Oh, well.
Is that okay? And then,
Oh,
you
yeah,
know,
we'll
there's
be
time for
fine.
Q and A, before it ends. That'd be good. Yeah, because we have classes right after.
And how should I address you, Professor?
Me?
Mm-hmm.
You're gonna address me?
I was just going to say thanks.
Oh,
Is it Mel? Mel?
Melvin, but you can just, yeah, you can say Professor Melvin, or you can say Max, or
Okay.
hey, you.
You over there. And the woman, was it, it's A?
Well, it's funny, her name is spelled Eileen, but it's Eileen.
I'll write it as Eileen, that way I know. That's very unusual. Glad I asked.
We'll do another couple minutes to students. They tend to sit behind, sit far back,
Like church. Way back.
too close, you might get picked on.
Right.
So I will give you a brief introduction. So, issue 2 went down in flames. That's what happens when farmers spend 7 million.
I think there was mass confusion too.
I don't, the pro campaign made a number of, could have done some things better.
Mm-hmm.
For one thing, don't put that provision in the ballot measure without
That
lawsuits. Yeah,
I think that was
that was
what people lasered in
a
on.
lot of people said, oh, this is just a lawyer's relief act or something, or somebody's going to get rich on this.
That's what a lot of people on our side
Yeah.
turned off by.
And then the idea that, they'll just raise prices to others, to other people. I think a lot of people felt that. And a lot of people told me that they just assumed it was a bad idea because all of the medical groups came out against it. And so it's an interesting question of why did all the medical groups come out against it? I didn't ever speak to any of them, but my guess is that they just saw this as potentially interfering with their ability to prescribe what they wanted to prescribe or something like that.
I think
And they don't like government pulling out prices because the next price is what we want.
well, ultimately, yeah, I can see that.
But do you have a better?
I just think that what I've heard on my side is we had concerns about
Well, you had
how,
340B.
yeah, and I told you, you were on the panel with me, for the safety net provider, we have a concern perspective how drugs are priced and paid in our sector. Um, but the people on my side, they were confused that provision about the lawsuit tax credit where left a bad taste in a lot of people's mouth. So I trust it's still going to be an issue. We got to sit down and talk together about what's the more appropriate solution.
Yeah, I mean, something's got to happen. All right, I think we can get started. All right. Good afternoon, ladies and gentlemen, and welcome to today's Elena and Miles Zaremski Forum. These forums are made possible by an endowment from Miles and Elena Zaremski. Miles graduated from this law school in 1973. Our guest today is Tracy Carter, Senior Director of Government Relations for the Metro Health System of Cleveland. Prior to joining Metro Health, Ms. Carter was Director of Government Affairs at Summa Health System in Akron. She has served in numerous leadership positions in efforts to improve health and well-being, especially for women and girls, and she has received numerous honors to recognize all of the good work that she has been doing. Her talk today is entitled Attorneys as Advocates from Creating Policy on Paper to Improving Lives in Person. So please join me in welcoming Tracy Carter.
Good afternoon, everyone. I'm so glad to be here. It's a beautiful day in Northeast Ohio. I want to express appreciation to Professor Max and to Eileen for extending an invitation to me to talk about healthcare matters and the role of attorneys in that sector, and look forward to sharing what I know and hope we can have some dialogue at the end relative to how attorneys could be advocates, partners with some challenging healthcare matters moving forward. So with that, I'm going to get started. When I was first invited to address a group of future attorneys, current attorneys, some things came across my mind. This cartoon, my fees are quite high, and yet you say you have little money. I think I'm seeing a conflict of interest here. So there's some of that negative perception out there about your profession. The other one with individual swimming, the lifeguard posted on duty, and then next to him is a personal injury lawyer. So strategically placed, waiting for business. So some of those perceptions I know you have to fight because at the end of the day, you are study training to better help individuals and entities with their personal and professional endeavors. And so for me, I've been in healthcare going on almost 30 years in about 2 years. I started right out of high school. I was fortunate enough to be mentored by a CEO in Akron and had a lot of time spent with him and his executive team. Of course, an attorney is a part of that team, and just really had a different view, a different take on what attorneys are wired to do and could do on behalf of individual and, again, entities, personal and professional endeavors. So for me, because this is Thanksgiving week, I wanted to just reflect on some attorneys that have been instrumental in my life. The first, Jackie Silas Butler. She is attorney. She practiced law during the day, and in her spare time, she was very active in organizing, aligning different leaders around youth and education leaders. And so she actually was the first attorney that I came across when I was at an awards event in high school, and I was just always in awe of her. That she was the first professional I saw, first professional attorney that I just highly respect. The second person I am thankful for is Belinda Hinton. She's, again, an attorney that practiced during the day, but figured out how to dedicate her time to making sure that young people, particularly those in the urban environment, have exposure to politics and policy. When I was competing for a position with the Close-Up, I don't know if many of you are familiar with that program, but it essentially takes young people, high school age students, takes them to DC. I believe we went for a week and just had a chance to be immersed in policy and politics with senators and representatives, and that experience forever changed my life. And I didn't know at the time that I would be on the pathway in advancing policy and politics on behalf of a major employer. So Ms. Hinton, I again really am thankful for. Her sorority actually came up with the money for me to participate in Close-Up years ago. And then the last gentleman, Mr. Bill Powell, he was general counsel at UH, and when I met him, he actually provided general counsel support for Summa Health System. And what I'm really thankful for is Bill actually was my go-to person in the leadership team around health access and coverage matters. He was on my team when we talked about what's our role corporately with Medicaid expansion matters and whatever I needed to advance from a policy perspective or political perspective. He was able to say from a legal perspective, this is what we could do to best protect our patients' interests. And Mr. Powell also was instrumental in helping me launch a medical legal partnership at SUMA. All right. A medical legal partnership model. That was just a wake up, make sure everyone's alert. A medical legal partnership model on behalf of our women and children's clinics. So those three individuals, again, when I thought about attorneys who have been instrumental in my life, personally, professionally, I just had to share that with you because I believe in giving people honor and credit where it's due. So because of them, I'm here today. Professor Max asked me to address you all, talk about some of the things that keep me up at night as a lobbyist for a healthcare system. So I'm going to talk about Metro Health System. I'm going to talk about some of the emerging health policy matters that are facing our system. I want to go through how attorneys are helpful to us from a policy and to also from an advocacy perspective, and then we'll open it up for questions and comments. So Metro Health System, I believe most of you are aware, we are the third largest health system in Cleveland, Colga County public health system. This is our 180th anniversary year. I could tell you that public health systems are almost rare. I think there's only 10 in Ohio still standing. We are the second largest behind Ohio State. So we're doing a lot of great work on behalf of Cleveland, Colga County. Those are just some of the bullet points of what we're known for. We have a distinguished history from a public health perspective with respiratory care, polio, burn center. Most people know us for our trauma, life flight service. And I mentioned we are the largest, second largest public health system in the state behind Ohio State. And our expertise, again, a lot of public health and medicine advances. We do provide support to the jail population. We deal with the most severe physical and mental health challenged patients, and we also serve as the medical home for the foster care population. So a lot of good things are happening with my system. We've experienced phenomenal growth over the last 4 years. We had a new CEO who came in with a much more entrepreneurial background, and he's a risk taker, innovator. And so with that, we've been able to grow patient visits for our system. We now have over 7,300 employees within our system, and in most communities, you will find that the healthcare system, particularly hospitals, are usually your top 1 to 2, 3 employers just because of the demographics. Effective January 2018, we'll now have 3 hospitals within our system. Most people know our main campus, which is located on the west side of Cleveland. We will be opening smaller inpatient units at Cleveland Heights and Parma to better respond to community needs. And we also have ambulatory sites to meet people where they are in the community. And we also have partnerships with Drug Mart for express care. We are an academic medical center, take great pride in partnering with CASE to train the next generation of providers. We have one of the best designations for nurses within our system. And again, I mentioned we're very risk-taking and entrepreneurial with the leadership of Dr. Akram Boutros. And some of the things we're known for in the Medicaid space is better managing cost, quality, and outcomes for the Medicaid patient base. And then we just received great recognition for managing the Medicare population. We have about 10,000 lives that we are doing well with. And for those of you who are not in the loop, the biggest economic activity will likely occur over the next 5 years with our campus transformation. We were the first hospital founded in Cleveland. Our facilities are quite outdated, and so we've been able to self-finance a major transformation project, which will begin over the next 5 years. where we totally renovate our hospital campus to best practice facilities. And with that, so it's 5 years of development and another 2 years to take down the existing structure. So all in total, about 7 years economic development for this region, which is quite significant. What keeps me up at night? So the healthcare sector, as I mentioned, is a large economic operation, enterprise for many communities and even at the national level. At this point in time, we continue to consume a great percentage of the gross domestic product, which is a challenge. And that's why legislators are now more than ever lasered in on our sector in terms of trying to figure out how to get better outcomes, value from our industry. And so at the moment, if you've been watching healthcare news, policy news, the largest reform buckets fall into two categories: insurance reform and Medicaid. Insurance reform is all about the federal marketplace, and this is the vehicle through which people who earn too much from Medicaid can go and access health care coverage. And so at the moment, there continues to be debate about the federal government's ongoing support of subsidies to help people afford their premiums. The individual mandate is now tied up in the tax reform discussion. And then the selling across state lines is something that the Republicans would like to see move forward. Medicaid will continue to dominate the press from a federal and state perspective. The constant conversation is around who qualifies, who should be on, who should be off, the spending levels, the benefit design, meaning what's covered, what's not, and also the federal and state commitments. Right now, Medicaid is a federal-state partnership, and there's a lot of discussion about the federal government transferring a lot of the dollars, risk, responsibility solely onto the state. So that continues to be something we monitor. And Medicaid for a public hospital is quite significant because at the moment, 50% of my business comes from Medicaid and another 25% from Medicare. So anything around Medicare, Medicaid, most health systems would be at ready alert for this. But for me, more so than anyone else, Medicaid matters most for my system. And we were recently featured in the MACPAC report, which is the federal advisory body for Medicaid affairs to Congress. And this is a report that highlighted or featured 7 different safety net systems across the nation in their report talking about the ACA and its impact on local healthcare systems. And what they did is they took each system and did a profile on them, and this is what they contained in their report. But essentially what it's saying, Metro Health has a high percentage of Medicaid patients and a high percentage of low-income patients. More so than if you look at the regional average, we're like more than double in our utilization rate among your low-income populations. Then you look at Ohio, and even the national average is staggering to see that we have that percentage of low-income populations that we are accountable for. So I would tell you that it's an honor or a privilege to serve such a high percentage of patients, but with that, there's a lot of stress and responsibility that we're trying to figure out how can we best support this population moving forward, given that the very source of funding, Medicaid, is always being challenged or considered for reduction. Other policy priorities that are important to us, drug policies. We anticipate there continue to be emphasis on drug pricing. If this new nominee, Azar, is confirmed, he comes from Eli Lilly, has a strong track record in pharma. The 340B is a national drug discount program that is available only to certain providers if you have a certain percentage of poor or underserved that you serve. That program is currently on the table for review and reform. And then the opioid crises. There's a lot of discussion about what's the role of pharma in dealing with this epidemic. A lot of legislators that we've talked to, particularly at the state level, feel that we, the provider community, have a stake in this, and we do, and also pharma. So we'll see what comes from that. Technology is an important vehicle for healthcare. Right now, the question for Medicare is how do we better utilize technology to serve those patients who have no access to providers? And so it's one thing to use it, but then there's another to get paid for. And that's something that we're looking forward to educating our legislators about. The healthcare workforce, the population is aging. The patients are aging, our workforce is aging. So there's a lot of opportunity to figure out how we can better, as a nation, shore up our pipeline. We have shortages in the clinical side of the house and also non-clinical. For example, healthcare hospitals tend to be a large enterprise, a lot of real estate that requires individuals to maintain them from a engineering, carpentry, construction, and so forth. Those various trades are also experiencing shortage. So we got a lot of opportunity on our hand to try and educate and train people and connect them to jobs that are quite competitive and attractive in the healthcare sector. The latest issue that's on our plate is with tax reform. My system is taking a look at that because there are some provisions in the proposals, House and Senate, that could impact us from an employer, our foundation, research, and tax-exempt perspective. So we're currently looking at that. And again, the individual mandate was just something the Senate stuck in there. And so we're trying to figure out how we can try and counter that particular provision in particular. So any questions about the policy piece in terms of what keeps me up at night? Yes, sir.
From an insurance perspective, most of the major carriers are forcing low-income families to your network. Because MedMutual puts affluent people into UH, Oscars, clinics, and almost all the other insurance carriers say Metro Health only. So you're actually, the market is actually forcing and driving low-income people to your facility.
I'm not aware of that. I think that would be interesting to get facts on that. Where are you getting your source from? Okay, so you know what you're talking about. But I haven't heard that. Right now, we would say the insurance is one way people get to our system, and doctors. And we know that some doctors have a tendency to refer to us because they know the public hospital will take everyone, and we do. But I had not heard the insurance side of it at this point. But we do have some insurance products that we've introduced to better penetrate the commercial market. Now that we have better geographic coverage throughout the region, and in terms of our quality and our costs, we think we're quite competitive. So I appreciate you giving me that heads up. We'll take a look at that. Yes?
Do you see the tax reform reducing the Medicaid role? Because it will reduce, well, it will increase the income for people that are now qualifying for Medicaid. If their income is increased, then they'll drop off the Medicaid role?
I don't know if that income increase will be enough to kick them off Medicaid at this point. I know that's what they're saying. This is the benefit, but it could be. That could be a potential.
Because some folks are very close to the bottom.
Right. They are. And if they are disqualified from Medicaid, then chances are they will still qualify for the marketplace if that's still viable and operational. Yeah, if. Right. Great question. Any other questions? I could tell you that most of my colleagues, Cleveland Clinic, UH, all of us have these similar concerns and challenges, but the Medicaid bucket in particular is most concerning to me, just because, again, 50% of my business is tied to that program. So with reform, there's great changes, challenges, and opportunity. This is what our CEO says to us every time we meet monthly. He said we need to prepare for change. It's coming. We need to be flexible, agile, and innovative, and that's what he's calling us to do. So, for example, with Medicaid reform, there continues to be discussion and debate around which is the best model for the nation and in states, the block grant versus per capita. And because we know something will ultimately stick, we're starting to say, okay, if a waiver is where the feds want to go in terms of giving states more flexibility, how can a Metro Health thrive under that model? We did it before, expansion of the state, so we're starting to think through that in terms of what can be the best pathway for Metro moving forward. With insurance reform, there continues to be a lot of interest in eliminating subsidies ultimately. And so if people lose that as a coverage option, we are trying to figure out what can we introduce to the market to better support those particular patients. And the gentleman in back mentioned the Cleveland Clinic, for example, that Oscar is one tool that they're using to attract new business to their system. So those are the things we're thinking about just to prepare for what's to come. And all of those challenges, those opportunities, we rely a great deal on attorneys to help us think through different strategies and so forth. From a government relations standpoint, I work a great deal with finance and legal. And so what I think attorneys are very skilled in is helping us think of the legislative language to best protect our interests. And so my former CEO used to always say, you never ask a lawyer, can I do something? It's best to ask, what can I do? How can I do this? And the attorney will activate his best thinking around strategy. And so with these issues, I'm partnering with our legal team. And for us, when we're looking at Medicaid policy, drug, technology, all of those different matters, for us, from an advocacy perspective, anytime we can introduce, modify, get something delayed, or a proposal completely abandoned, that's success, depending on what the issue is. And so that's what I'm looking to do more of in partnership with our attorneys, because we have a lot. I consider it to be a tsunami of changes coming our way that we just have to be prepared to navigate through. We welcome partnerships with the attorneys. Again, you guys excel with critical thinking, policy, research, analysis, and formulation. I'm looking for more advocates to help speak up, fight for the uninsured and underinsured. And it's an important piece. There's policy, and then there's the advocacy, where you actually roll up your sleeves, engage with the particular constituent or constituencies that are impacted, and figure out a pathway to best protect their interests moving forward. And so that's what I'm hoping as you all move through your studies, your practice, your careers, that's something you figure out. And I will tell you that working on behalf of the low income or the poor populations is definitely harder work, very harder work. You have to have patience, you have to have restraint, because you'll be interacting with some people who are just completely idiots, who don't refuse to understand another person's situation, and that could be quite challenging, but you have to be focused on your goal, be resilient, and continue to press forward. And the reward ultimately is, I think, very big if you can get some home runs on behalf of the underserved groups. And again, healthcare, being a public hospital, this is something that we take very seriously. And just to give you some examples where a lot of attorneys activated their advocacy hats, when Ohio was considering Medicaid expansion as part of the Affordable Care Act, on the pro side, the advocacy side, attorneys were stationed. They knew the policy side, but said we have to do a statewide advocacy campaign to make sure that Ohio adopts expansion. And so with that, we had the attorneys draft the plan. They actually activated different regional bodies who actually organized grassroots leaders to actually go down to Columbus, do op-eds, do testimonials. We did almost any and all things we could to get across the finish line. And I think what really spurred a lot of the attorneys into action was after they really dug a little deeper to find out who needed or who could benefit most from expansion. And so these are some stats that we had published back in 2012, 2013, when we were gearing up for the Medicaid expansion fight. Veterans, the mentally ill group was really a population that people understood, because most people knew someone in their family or in their network that was struggling with that. There was a good percentage of people who were working all their lives. They were let go. They had life happen, and they were struggling to get reconnected back into the workforce, but still needed help. And then there was, at that time, again, this was about 3 or 4 years ago, there just was starting to be a rise in the number of people who were struggling with addiction. So after our attorneys who were leading this charge understood who was impacted, that really gave them the fire to move forward and do what they do best in terms of the policymaking and advocacy to get this adopted for the state. And again, they used their time, they used their talent, they used their treasure. I had a number of attorneys call me and say, I'm here. Personally, I'm not representing my organization. I had one come and approach me and said, my church sent me. What can we do to be helpful? So be it publicly or behind closed doors, your time, your talent, your treasure on behalf of those who really don't have great access to power and wealth is greatly appreciated. And I will tell you, Medicaid expansion is not a done deal. We'll be back at it come 2018. It's just a constant struggle, but I say of all the fights, this is a good fight to fight. Another example of attorneys serving as advocates, the medical legal partnership model. Metro Health has one of the first MLP models in the state, in the country, I believe, where we actually partner with attorneys to better serve vulnerable populations. And right now we have 4 attorneys that are stationed in our frail elderly clinic, women and children. We have 1 at the jail, and there's a 4, I think, in a primary care site, just to better help people navigate through complex legal situations. And so we had representatives in from Renee C., Bob Gibbs, and Representative Joyce on Friday, just to talk about the work we're doing and how we could use their help at the federal level to help consider reimbursing attorneys for their time in helping screen patients for legal issues. Because we've learned through time that if we're able to help stabilize their social or legal situation, the stress is lifted and the health outcomes have a chance at being improved. So that's something that we were sharing with our delegation members, asking for their help to promote policy and regs rules to make sure that moving forward, attorneys can be paid for their time. And one other issue I see brewing, this is just an opportunity for attorneys. Again, the MLP advocates are partnering to try and change federal law. And relative to federal law, again, my senior counsel said, what is complex to a patient is simple to an attorney. We can improve lives with our services. And when we started to talk about Medicaid matters a little bit more, we started to talk through what the new or the current CMS director, Seema Verma, has been promoting within the last week. Again, this is around states having greater flexibility around the Medicaid program. And the focus is on the working age, able-bodied citizens who now have Medicaid, and the goal is to ultimately help them move out of poverty. And so there is a segment of the population that I don't think the policymakers are considering that want to work but can't work. And one group are the individuals who have a felony background. In Ohio, I think there's about 700,000 individuals who have benefited from expansion, and it's about 30,000 that fall in this bucket. And so the question is, what can we do with law that would help those people have an opportunity to ultimately work, if the goal is to make sure that if I'm receiving that benefit, I am able to work. So we have to figure out how to work through that, because in my sector in particular, we cannot hire anyone with a felony background. So how do you reconcile that? And again, I think attorneys can help us think that through. And just looking forward, my encouragement to all of you is just to continue to use your gifts and policy formulation and execution. Activate the advocate in you by listening to and interacting with the people who are actually being touched by policy. And I do believe with advocacy, more meaningful and transformative policy is created, because I think once you get in the weeds, working alongside those who are impacted, you are in a better position to actually draft and execute policy. And if you're interested in healthcare access and coverage matters, please call me. I always could use as many advocates' voices as possible. And this is my closing slide for you all. Life is short. Pick your causes wisely, because that sometimes you can pick one that you just won't have a good shot at winning. So do not choose to advocate on behalf of a flock of turkeys. So with that, thank you for your time. Any further questions, comments of me? Yes, Professor.
I don't know how many of the audience would understand why would veterans need Metro Health when there's the VA?
Right.
How were those 26,000?
Great question. So what we know to be true is not everyone wants you to know they were a veteran. I mean, even when they come to us, a lot of times we do not know that they won't disclose it, and there's some issue with the VA. And I believe also that to qualify for the VA benefits, there's certain criteria you have to meet, and there's a section of people who just do not qualify. And what we found, it tends to be the younger group that is not accessing the VA system for a variety of reasons. But that was a surprising fact for us. There is a section of VA or veterans that need the private system for care.
Yeah, my wife works at the VA, and she this surprised me, and I asked her, and she also pointed out, in addition to what you said, that if your healthcare problem is not service connected, then there's a real limitation on what benefits you can get from the VA, and that's another problem.
Yep.
And people don't understand that in this country.
Right. Right. So yeah, that was news to us, but we advocated for them. If anyone should have access to health care, it should be our veterans, for sure. Any other questions, thoughts, comments? Yes.
Just stepping back, you spoke very briefly, sort of more of the policy role, about the opioid effect. I was just curious, the health system does embark on this substantial investment in infrastructure, and it sounds like some expansion, and we as a state are grappling with how we're going to respond to this problem. So that seems to be growing more and more. I was just curious how you might be interacting with the state legislature, with state policymakers, and how that may have impacted Metro Health's plans in the immediate future as we sort of try and figure out some sort of response to this crisis.
So right now, most providers have been interacting with the state around licensing and credentialing issues. That's the biggest opportunity, and we've also been asking for access to, there's a program, I can't remember the formal name, but it tracks the prescribing patterns of doctors. And what the opioid experts are saying is we need to get access to that system. I think it's ORS is the name of the system. The goal is to get access to that data so they can better understand the prescribing pattern, where the red hot zones are, and try and intervene from an education and training standpoint to better help those providers not rely on opioids as much. And also what the researchers are trying to figure out, okay, if we're moving away from opioids, what's the best alternative for pain that we should be helping our patients accept? And so that's the other piece of it. So right now, licensing and credentialing, we want to do better research. Metro Health has been very proactive with opioid. We have Project Dawn, which is the deaths avoided with naloxone. We started that a few years ago to help those people who are ODing and trying to bring them back to life, but we said that was reactive. How can we get ahead of it? So Dr. Joan Papp is your regional expert. She actually helped launch the Office of Opioid Safety, which is going to be the first of its kind within this region. She has a partnership with CASE, I believe, to deal with opioid from the education, awareness, prevention, treatment, and research angle. So we're just getting started. Unfortunately, the crisis is continuing to escalate, and it's quite complex. it's quite complex. What's scary is what used to be considered just now a suburban issue is now urban. And it's just, I think a lot of doctors are like, public health officials are like at a loss of what to do. But we've been encouraged to look at this or treat this like it's a public health emergency like it is, figure out, get some lessons learned in terms of how we dealt with HIV/AIDS, and see if we can do a better job at managing and preventing this moving forward. So that's where we are.
Can I just ask, what is the licensure and credentialing focus that you described? What is
There was
going after doctors who should have disciplinary action?
there was a of course, you know, doc versus nurse, who should be prescribing what, how much, limiting what you could prescribe. Like some people were doing 30. I think now they moved back down to 7, now to 3-day. Those are the type of issues they're dealing with. And then the providers have concerns about people who are, if you go on corners, they're offering access to different drugs to help you tolerate or withstand your addiction. And the doctors who are associated with the health system are saying that doesn't help the patients. It's like a one-time thing. These people need to be in the system with a more coordinated, specialized service to have a shot in trying to heal. So those are the type of things we're dealing with. The good news is the doctors in this region, all the health systems are in a room together talking this stuff through, making sure we're on the same page moving forward. But it's eye-opening to see that, I don't want to say we're losing, but we're like overwhelmed because it's just escalating, unfortunately. Any other questions, comments?
I have one other, if I may. I'm sorry, you mentioned Medicaid waivers before, and Medicaid waivers before and after the current effort to change how Medicaid runs. I don't know if people understand very much about how important the Medicaid waivers have been.
Basically, the waiver gives you an opportunity to flex or waive certain rules so that you can test new practices, care delivery, or financing for Medicaid patients. So before Medicaid expansion was adopted in 2014, Metro received this waiver to enroll. We had about almost 30,000 uninsured patients accessing our system for care. And we said, why not be proactive and get those people in like an insurance program and teach them how to access the system from a primary care, specialty care perspective, et cetera. So the federal government, state government worked with us to approve that model to let us enroll those people into a insurance coverage program. And so that was 2013 when we received their approval. Then Ohio adopted Medicaid expansion in 2014. And so the state said, instead of you guys continuing to operate your separate model, we're going to enroll those 30,000 into the Medicaid expansion population. So what will change moving forward is I think we will continue to have that same flexibility, the same waiver. I think there are some things around patient incentives, beneficiary incentives that we will probably test just to better teach and educate people on how to access the system that we'll probably try and test with this new waiver model. So those are the type of things that we're thinking through. But like I said, something's going to drop, that block grant or that per capita, which will fundamentally change how Medicaid is managed in this country. And so we as a major Medicaid provider are trying to say, we need to get ready. And a waiver is one tool we'll use to think through that. Yes?
Do you have any good ideas as to how we can make people with felony records more employable? Because that is a huge problem, I think.
Well, I will tell you that there's a team at Metro Health, and I think there are another set of employers that have been working with Oriental House and the county to think through what you just said. Certainly those who have violent past, or if you had like a, what do you call it, the major theft, those are some things that we will have concern about, but I think all other issues we could probably work through, because the healthcare sector is more than just a doctor, nurse. There's great diversity in what you could do for a health system. So we are having those conversations, but it's something we have to figure out because we have shortages in our sector. When I talk to other major employers in town, I was talking to First Energy last week, everyone has jobs. And it's like, where are we getting the talent? A good percentage of people who come for jobs these days cannot pass the urine test. And so it's like, where else are we going to get these individuals? I mean, you can look at your current workforce and retrain them for other opportunities, but there's a great section of employees out in the community who did their time, paid their dues, and looking for a way to get into a job so they can get health care, so they can make a living, et cetera. So we're thinking that through. But Oriana in this region is like the lead advocate on that issue. Yes.
You know, you mentioned there's a lot of issues that we talked about, but selling insurance across state lines.
Mm-hmm.
Right now, we're in our system is based on states being individualized and having their own insurance. I don't know, the agency in the state.
The Department of Insurance manages that. Mm-hmm.
Each one is different and set up different. It's my understanding. I don't know a lot about it, but how would you foresee how that would work, selling insurance across state lines? Are there standards and guidelines for each? I mean, wouldn't it have to be standardized in some way because it's like going to each state has their own Department of Insurance.
So yeah, Department of Insurance would dictate how that would work in our state if it moves forward. We always have concerns from a provider's perspective because typically what happens is with that model, many plans have many offerings, a lot of them at lower rates. We would have concerns about what the coverage would be. A lot of people buy insurance thinking they have full coverage, and they'll come accessing the system thinking X, Y, and Z services are paid for, when in reality, no, only X is covered. And so from our perspective, because we've had this happen to us several times over, people think they have full comprehensive service, they have very limited benefit, they'll come accessing the system, and when it comes time to settle the bill, guess who's on the hook to eat the debt? Because the patient doesn't have it to pay. Insurer will come push back and say, no, this is what that person signed up for. So we eat what we call it's called uncompensated care. So we have concerns about selling across insurance lines because we don't think patients fully, they're looking at the price, and not all patients are looking at, okay, for X dollars, what am I getting? And that's a concern. What is MEC? Oh, that's that's a big part of this whole state flexibility.
And I think part of the resistance to having health insurance that you're paying maybe $10,000 a year, but you're not getting anything of value in return, even having health care checkups or just the basic what the guidelines are for the mammogram effect. And you know, it's like you're throwing money away. You know. So
yeah, so that we have the similar concerns about what people are paying for and what they get for what they spend, and a lot of people just don't understand it. It's quite complex, more complex than it needs to be. Not everyone could have access to a broker to walk them through the details of that plan, unfortunately. I do know that most health systems have, we used to call them financial counselors, but I think they call them something different these days, patient access counselors. So if people have questions, they should call and say, I'm a patient of X, we're not allowed to tell you which plan to choose, but we could say certainly if you have X, Y, and Z health conditions, you probably need to be looking for a plan that offers you X type of coverage. Yeah, high users need comprehensive coverage. Right, if you're right, that's what most patient advocates ask, so they can better help you understand which plans you should be considering.
And that's another question I had on patient advocates. What do you see as their role? Or, I I know you can hire patient advocates now, you're, say, I'm single and I need to go in the hospital and I don't have any family, but I need somebody to watch, what my doctor's giving me and that, because I've had issues with some of the drugs they try to prescribe and they're going through and you say, no, that was really not appropriate.
Mhm.
In the hospital, the doctors float in and out, and a lot of them don't really know you.
Mhm.
I've had those situations happen. So what do you see as a patient advocate's role, or do you have that?
All I can tell you is that Metro is now, most health systems are talking about population health, and what that is you being responsible for a certain population, like behavioral health or the addicted, women, and because a lot of us are moving down that pathway, we're trying to say, what's the best support we can give patients to help them navigate through the system? Some of them are called navigators. I know they do this a lot for cancer, but my CEO was just mentioning that he's thinking about, I want to say life coaches or health coaches to better assign to those higher risk, higher cost populations so that a patient and the caregiver could access them to get better advice on how to move through the system. So that's something we're thinking about, and that's all I know at this point. Mm-hmm. Yes. Right. They need more support, and we found that in one population, they were so sick, the frail elderly, they need to be touched at least 3 times a week. That's what we have, this pilot program going underway where we have the doctors, social workers. I mean, they are high need individuals, and so we said we need to be touching them more frequently to help them be well and stay out of the hospital if possible, because they could actually do better at home with the right home, like what do you call it, home care nurse, and even technology. They're starting to use technology to better monitor people from afar. And we do have a doctor house call program too, going back old school.
Any last questions before we thank? Well,
We can talk offline.
yeah, I'm gonna let the students go because I know they have to get ready for class. But please come up and talk with Dr. Carter on lunch.
Not a doctor. Thank you. And I have business cards if you guys need to contact me down the road or have a question about healthcare policy. You can grab my business card.